So, where we left off the other day on Tuesday, we finished talking about the four layers of the tract, the mucosa, submucosa, muscularis, and serosa. Okay. Now we're going to continue talking a little bit more about the serosa here on this page, where we will discuss what we call the peritoneum. Peritoneum is something that we have actually talked about. You have to think all the way back to the very beginning of the semester, though, when we looked at our very first lecture. We learned there were three serous membranes. We've recently talked about two out of those three. The pericardium with its two layers, parietal and visceral pericardium, surrounded our heart. In our last lecture, we talked about the parietal and visceral pleura. Here we're going to talk about the parietal and visceral peritoneum. This is our largest of the serous membranes of our body. Consists of a layer of simple squamous epithelium, what we call mesothelium, and an underlying layer of areolar connective tissue. So what we actually talked about last time at the very end of class, and what we were actually talking about was this visceral peritoneum. Covers some of the organs in the cavity and is their serosa. Key is some of the organs. This is the deeper of the two. This parietal is superficial, just like what we saw with the parietal pericardium, parietal pleura. Okay. This lines the abdominal pelvic cavity. Okay. In between there is a space we call the peritoneal cavity or peritoneal space, where there's lubricating serous fluid, okay, and helps those organs kind of slide over one another and prevent the membranes from having friction. Some organs lie on the posterior abdominal wall, though, and are actually covered by the peritoneum only on its anterior surface, which means they're actually located behind and outside of the peritoneal cavity. These include your kidneys, which are not digestive organs, but we'll be talking about them. That'll be in our next lecture. We'll get into that next week. The ascending and descending large intestine, the duodenum, and the pancreas, which are all things that we'll be talking about here today. We classify those as retroperitoneal. So like if you were doing a dissection, you'd really have to kind of dig some stuff out to find them, and they'd be covered with this shiny visceral peritoneum on their front side, and you'd have to cut it out to find those organs. Okay. Unlike the pericardium and the pleura, which cover our heart and lungs respectively, our peritoneum has large folds that weave between the viscera. Remember, viscera is just a fancy word for organs, binding them to one another and to the walls of our abdominal cavity. They also contain blood vessels, lymphatic vessels, and nerves to supply those abdominal organs. 5 major peritoneal folds include, I include this picture of a cadaver where you can see this nice gross looking stuff. That's the greater omentum. The greater omentum comes down from the transverse colon, kind of like a apron, and covers the majority of those abdominal organs. Mainly we're talking about covering up the small and parts of the large intestine. Here it's been removed so we can see them, because like right here in this cadaver, you can't even see those organs. Pretty gross. And I say that, when we like dissect cats, when I get to do that on campus, it's really kind of gross looking. It's fat, basically. So that's why it's listed here as a fatty apron. It's a double sheet that folds back on itself. And as I said, it's made up of adipose or fat tissue. And this can actually greatly expand with weight gain, giving rise to that characteristic, as we like to call it, a beer belly. If I go back to the very first page when I had this picture of the abdominal organs, that greater omentum's removed, but we can see the next peritoneal fold here in between the two lobes of the liver, what we call the falciform ligaments. The falciform ligaments also shown down here at the bottom of the page. It's also a little bit visible there, not quite as well as that first page. It just attaches the liver to the anterior abdominal wall and the diaphragm. Okay, we talked about the greater omentum. There's also a lesser omentum, which is an anterior fold in the serosa of the stomach and duodenum. Suspends the stomach and the duodenum from the liver. In order to see it, you have to kind of really lift the liver and gallbladder up out of the way to show that lesser omentum holding the stomach and duodenum in place. The mesentery was what was actually visible here on this previous page. You can see it's actually labeled. Mesentery is a fan-shaped fold of peritoneum binding the jejunum and the ileum, which are the second and third segments of our small intestine, to the posterior abdominal wall. Yeah, you kind of to really be able to see them, you kind of have to, like pull the small intestines kind of out. Now, the small intestines aren't going to just fall out of the body because that mesentery would be holding it in the shiny membrane as it looks like in real life. The mesocolon includes two separate folds of the peritoneum binding the transverse colon and the sigmoid colon of your large intestine. Anytime you see colon, that should be a direct indicator that we're going to be dealing with the large intestine, because the majority of your large intestine is, these things: transverse colon, ascending colon, descending colon, sigmoid colon, all are different parts of the large intestine. So colon and large intestine go together. Very much so. As far as the pictures go, I'm not going to worry about you knowing them. We've got enough pictures to worry about, not the most important things. So don't study them, just the information. Okay, now we are ready to start at the top, working our way down the track through the various organs of our digestive system. We'll start with our mouth, which is actually a pretty darn complicated structure. If I could call it a structure, I guess. Cavity, I guess, would be a better way to describe it. All right, let's talk about the tongue, or the tongue. The tongue will be discussed, but the mouth, also known as oral cavity or buccal cavity. First part I want to talk about are your lips. Lips are also, and this is more an anatomical term, known as labia. Labia with an A at the end is plural. Labium, I-U-M, would be singular. Covered externally by skin, internally by a mucous membrane. Junction between the skin and the mucous membrane is highly sensitive. Our lips help with assisting to, form sounds, but also with eating. Down at the bottom, what they've done is they've opened up the mouth, as you can see, say ah. They've pulled the lip up for the superior lip and the lip down for the inferior lip, so that we can see what we call the inferior and the superior labial frenulums. Okay, these you can actually feel, you can stick your tongue in front of your teeth on the bottom or the top of your mouth to feel them. They're just little pieces of mucous membranes, kind of help attach the lip to the corresponding gum line. All right, your cheeks are the lateral boundaries of your oral cavity and are continuous with the lips, also lined with the mucous membrane, just like your lips. That space there that I was just talking about, where you could put your tongue to feel the superior and inferior labial frenulum, is called an oral vestibule, or they just have it down here labeled as a vestibule. This would be like the little pocket where a person would put chewing tobacco if they chew. It's bounded externally by the cheeks and lips, internally by the gums and teeth. Another region of your oral cavity is called the oral cavity proper. That's all of this space that's behind your teeth, so posterior to the teeth. So where your tongue is at, it runs from your teeth all the way to the opening into our throat. And that opening to the throat we talked a little bit about in our last lecture. It's called the fauces, which is, as it says, just the opening between the oral cavity and the oral pharynx or throat. We talked in our last lecture about both the hard palate and the soft palate. We didn't really talk much about them, but we learned that the hard palate and the soft palate form the floor of the nasal cavity. They also form the floor of the roof of our oral cavity. Hard palate's formed by two bones, two maxilla, two palatine. It forms about the anterior 2/3 of the roof of your mouth. About the last third or so, posterior third, is your soft palate. Soft palate is between the mouth and the nasopharynx and is made up of muscles arranged in an arch structure. There's actually two arches that are part of it. The palatopharyngeal arch is more posterior. Palatoglossal arch is more anterior. You can kind of see the arch that's been drawn in here. The palatine tonsils are located between the two arches, or the palatines are the ones that a lot of times are removed when a person has a tonsillectomy. Those are the ones that are being removed because they can interfere with that opening, that fauces, almost projecting all the way to the uvula. The uvula is that thing that looks like a punching bag in the back of your mouth, hangs down from the soft palate, and actually functions. A lot of people don't even realize it does something, but it's very important. When you swallow, it rises up to close off the nose, preventing any food and drink from going up into your nose. If you look in a mirror and you open your mouth, you can mimic swallowing. You can see that go up and down. It's kind of cool. Your tongue is a solid mass of skeletal muscle covered by a mucous membrane. It functions to help with masticating. Mastication is just a fancy term for chewing. So it helps move that food around and create what's called a bolus, which is just a ball of food plus the saliva that we will then swallow. So it's very important for chewing, but also swallowing. Also helps with forming words. We talked about that in our last lecture. Extrinsic muscles are muscles that originate outside of the tongue and attach it to the skull and neck, moving our tongue side to side, in and out as well. When we talked about our muscles of the body, there was a slide where we had the hypoglossal, styloglossal. Told you not to worry about them, but those were those muscles. So we've talked about them before. Wasn't something I focused much on. Within the tongue itself are intrinsic muscles originating and inserting into connective tissue within the tongue. And they're going to help change the shape of the tongue for swallowing and speech. Like if you can roll your tongue, that would be those types of muscles responsible for that. Anytime, and I've talked about this many times this semester, you see the term lingual. Lingual is a term that refers to tongue. And so lingual frenulum is this fold, just like what we saw with the labial frenula. It attaches, in this case, the tongue to the floor of the mouth. Our tongue actually has glands within its connective tissue layer, within its lamina propria, helping to secrete fluid into our saliva. What's in it would be mucus and a watery fluid containing an enzyme, lingual lipase. I know looks like the word kind of got cut off a little bit, but that's a G and this is a P. Lingual lipase helps us digest fats. Our tongue itself, we've talked about this before, consists of a root body and a tip. Not super, super important. Now, this is a very important image. Make sure you highlight or just, star the entire thing because everything would be fair game in it. There's something that is very prominent in our mouth that I haven't talked about yet. Or should I say some things? They're labeled here. What am I referring to? Teeth. Teeth, obviously very, very important for digestive purposes. Let's talk about them here on this page. So for you people out there that are wanting to be a dental hygienist, I don't remember if anybody in this class is, but Here's your time to really focus in. Fortunately, we could go into a lot more great detail on teeth. We just don't have the time. But we'll discuss them fairly in depth at least. All right, our teeth are embedded in the sockets of both our upper and lower jaw bones. Remember, upper bones are the maxilla, your lower jawbone would be your mandible. The sockets we learned all the way back when we talked about the skull and those different bones are called alveoli. And actually, they don't label it there in our picture, but the little sockets where the tooth is located will be an alveolus, not to be confused with the alveoli of our lungs. I don't know why, but a lot of times you can, find organs and stuff, parts of organs labeled and named the same in different parts of the body. Associated with our teeth are our gingivae, or gums as we typically call them, which surround the teeth, and you can see those are labeled here on the previous page. You've probably heard the term gingivitis. I remember a commercial, I think it was for mouthwash. You suffer from gingivitis. That's, inflammation of your gingiva, of your gums. Okay, our teeth are actually pretty complicated. What we have down here at the bottom is a sagittal section, so the tooth has been cut in half. First thing I want to talk about are the three kind of sections or regions of a tooth: the crown, the neck, and the root. The crown is the portion that's visible outside the gums. The root is the portion of the tooth embedded in the jaw, which should make sense, like a root of a tree. Typically, roots are underground. In this case, embedded in the jaw. And then the neck is the region at the gum line where they meet. So it's a very small segment between the crown and the root. Okay. Other parts are labeled, which include your enamel, which is a hard non-living material that covers the crown. Actually is the hardest substance in our body because it's got a lot of calcium compounds in it. Very similar to bone, but it's actually even harder. More like bone is the dentin, the calcified tissue shown here in orange that makes up the bulk of the tooth. Okay. Like our bones, teeth are hollow structures. Okay. The space inside a tooth is called its pulp cavity, where we find blood vessels, nerve endings, and fluid called pulp. Okay. So that's the pulp cavity. There's also what we call a root canal that travels down into the root of the tooth. You've probably heard of a root canal procedure, okay? When a person has a really, really bad cavity and the root is infected, they'll drill all the way down into that root canal and clean things up. That's probably not the most pleasurable experience. But this is just a narrow extension on, in this case, both sides, because there's kind of two parts to the roots. Not all teeth have this kind of double root feature, but those run through the root of the tooth. Each root canal has an apical foramen, which is a tiny little opening at the deep end. That's where the nerves and blood vessels are able to penetrate into the tooth. Okay. What did I miss? Oh, cementum is a bone-like substance covering the root, and that's labeled, it's very small in here, but that's what is this kind of white membrane. The little things that almost look like, to me, little pieces of spider webbing would be a periodontal ligament. Periodontal ligaments we actually talked about previously help bind the tooth to the bone. In this case, they have it labeled as alveolar bone. It could be, upper or lower. In this case, I guess they have it lower, so that would be the mandible. Okay, make sure that you can identify everything in this picture that is all capital. So the 3 regions and then all the different parts that we talked about. What you don't need to worry about are like the alveolar bone, nerve, and blood supply that are not completely capitalized. Over on the right, we show a comparison between a child's set of teeth and an adult set of teeth. Humans are described as having differentiated teeth. What do I mean when I say that? Anybody have a guess?
Like some of the teeth haven't grown in yet.
Nope, that's a good guess though. What does differentiated teeth mean?
Different size teeth.
Different types of teeth. Okay. Run your tongue across your teeth. You'll feel different shapes and features to them. We are, not everybody chooses to be this way, but we are built to be omnivorous, which means that we eat meat, but we also eat veggies, right? Okay, whether people do that or not, that's a personal choice. But no, we're not like some animals that strictly eat meat or strictly eat vegetables. Okay, so we have to have teeth that can do kind of all sorts of different things. Okay, our first set of teeth, and I just kind of encourage you to kind of just use your tongue to walk yourself through these, are your incisors. These are the front teeth. There's 4 on top, there's 4 on the bottom. They come to a nice chiseled point, okay, and are great for just biting straight into the food and chomping right out of it. Okay, there's the 4 lowers, the 4 uppers, and so there's actually classifications as central incisors. Those are, what we would call like your buck teeth, and then there's 2 on the sides. Those are your lateral incisors. Following with your tongue to the side of your lateral incisors, you'll have a canine on each side. Canines are also known as cuspids. There's 2 on top, there's 2 on the bottom. They're called canines, and that's because you find them in canine animals. What are canines? Like dogs and wolves and foxes. Okay, if we were, Dracula, that would be the one that comes to a point and that you could bite into someone's neck. Okay, other term for them, like I said, are cuspids, or canines are really good at ripping and tearing food. So like with, like meat. Continuing, moving your tongue, you'll then find some teeth that are kind of still sharp, but not like the straight point that your canines come to. You're gonna be feeling your premolars or bicuspids. Also, aside from having points, they're kind of a little bit more flattened. We have 2 on each side, upper and lower. So there's 2 here, 2 here, 2 here, 2 here. That makes 8 total. Great for chewing and grinding food. Okay, we classify the into first and second premolars. Then you have 8 total molars, which are good for chewing and grinding food, just like your molars, but or premolars, excuse me. But they're more flattened, and these are going to be like what you find in herbivore animals, so like cows and that kind of stuff. That's what this one is actually. It is nice and pretty well flat on top. First and second molars exist. There's also third molars, which we commonly call wisdom teeth. Okay, generally come in your late teens, early 20 years. And these are, the annoying ones that typically have to be removed because they can overcrowd. The kind of cool thing is that some people have all 4, some people only get a couple in. Teeth are kind of weird. Some people even have like 3 sets of teeth. Some people don't even have a second set, or sometimes they're incomplete. I was pretty lucky. I must have inherited it from my dad. I don't have any wisdom teeth, never have. So I always like to joke that I'm just, genetically gifted, that I don't have to ever worry about having them removed because I never had them. I don't care about these 2 pictures. I wanted you to know the ones here on this previous page. They're all labeled here. They included the wisdoms. As you can see, there's 3 on this side. There's 12 total as a result. But I'm not going to worry about these 2 pictures. Okay, moving on. We're not quite done talking about the mouth. We have some accessory organs to talk about before we finish mentioning our mouth. Moving on. Let's talk salivary glands. Salivary glands are what produce our saliva. Pretty common sense there. There's several types and several different ones. And then there's these 6, these are all in pairs, that are going to produce the majority of our saliva. Okay. Saliva itself is almost 100% water. I mean, that is pretty dang close. Even though there's majority water, there's still a lot of other stuff in it. There's enzymes like salivary amylase, which I haven't mentioned, but that helps us digest carbohydrates. Lingual lipase, we learned about earlier, produced in our tongue, helps digest fats. There's a chemical called lysozyme that kills bacteria. There's also various proteins, antibodies, and ions. Our mucous membranes of the mouth and tongue contain many small salivary glands opening directly or indirectly via short ducts to the oral cavity. You have your labial, those would be on the inside of your tongue, or excuse me, inside of your lips. Buccal, those would be on the inside of your cheeks. Palatal, which would be up on your palate. Okay. The lingual glands are associated with our tongue, as we already talked about. They only contribute a very small amount to your saliva. Most of your saliva is secreted by these 3 pairs of glands that you had to write down. They're located beyond the oral mucosa, so they're located outside the mouth and have ducts that carry their secretions into various places within our mouth. Our first pair are the parotid glands. These are the largest. The term parotid apparently means near the ear, which is where their location is. They're just deep to the skin, between the skin and that masseter muscle that we learned about previously. And then you can see their duct carries the secretion between the upper molars, like we show right there. Okay. Your submandibular or mixed glands are going to run underneath kind of your jawline. Submandibular, hence the name, deliver their secretion of saliva on both sides of the lingual frenulum. If I go back to this picture, those 2 little openings, and you can actually see these openings. If you like look in a mirror and open your mouth, lift your tongue up, those are where the saliva from your submandibular glands comes from. Sometimes, you know, this is the one that if you yawn, will shoot that saliva out, what we call gleeking. And then the sublingual glands, remember lingual always refers to tongue. They are the smallest of our salivary glands in front of our submandibular, and there are several ducts delivering their secretions beneath the tongue. Now, we can only kind of really see them here. This is kind of a freaky looking figure. They've removed the cheek, obviously, but they've also had to remove part of the mandible so that we can really kind of see the sublingual gland. I do want you to know the 3 glands here in this picture that we can see: the parotid, the submandibular, the sublingual. I'm not going to worry about their ducts. I mean, that's pretty straightforward. You know, the duct is just connected to the gland. I want you to know the gland so you know the duct. Nothing else really I'm worried about you knowing. Down at the bottom, I included a cadaver view so you can see the good size to that parotid gland. In your cheek, the submandibular glands visible. We'd have to, you know, just like we did above, have a lot of this stuff removed out of the way to show the sublingual. It's not, but it's in there. Just didn't show it here in this picture. As always, I'm not really concerned about the cadaver view like I am the other. All right. First place we'll talk now is your pharynx. Like I said, we would talk about it again after the other day. This is involved with the act of swallowing. We got a fancy word for swallowing, just like we did with chewing. Chewing was mastication. Deglutition is the act of swallowing, where we move a mass of food called a bolus from our mouth down into the esophagus and then down into the stomach. Our pharynx is definitely involved with that. It's a funnel-shaped tube extending from the internal nares to our esophagus posteriorly and to the larynx anteriorly. It passes food to the esophagus through two of the three segments, which would be the oro and the laryngopharynx that we talked about last time. It's composed of skeletal muscle, which helps with the voluntary act of swallowing and is lined by a mucous membrane. We talked all about the pharynx the other day, shown here in green. We talked about that picture and all the different parts. So I'm just going to move on from it. We've got a good feel for it, hopefully by now. We'll talk about the esophagus, a collapsible muscular mucosa lined tube. It extends from the pharynx to the stomach. It's about 25 centimeters or 10 inches in length, about 4 centimeters or 1.5 inches in diameter. Posterior to the trachea and the heart, and the function of it is to move food to our stomach via muscular contractions known as peristalsis. Gravity does play a role typically, because generally when we're eating and drinking, we are sitting up. But you can like lay down or even actually be inverted, standing on your head, doing a headstand or a handstand and drink or eat. It's possible. It's not obviously recommended though. Each end of the esophagus is encircled by a muscular sphincter, which is just basically a ring of muscle. In this case, smooth muscle, an upper and a lower, and they act as valves regulating the passage of material. The upper esophageal sphincter is located at the upper end of the esophagus. It controls the movement of food and drink into the esophagus. Not quite as important, in my opinion, as your lower esophageal sphincter, which also goes by cardiac sphincter. It controls the movement of food out of the esophagus into the stomach, and it helps prevent stomach juices, especially the acid that's in our stomach juice, from going back up into the esophagus. Okay. Unfortunately, that does take place. The fancy term for that is GERD, gastroesophageal reflux disease. A lot of people call it heartburn, okay, where you can feel that burning sensation. If you've ever experienced it, you know what I'm talking about. And it's very, very dangerous to have continually happening, because the stomach acid will just kind of eat at the mucosa of the esophagus. And what we want is that to be a nice tight seal. And so, it's like recommended that, you don't go lay down after you eat. You stay vertical so that, you're not going to, take away the effect of gravity to help you. If you suffer from it, there are things that you can do to help prevent it. Chewing gum is actually a pretty good way of reducing it, just because you produce more saliva, and the saliva helps just slide down and keep that stuff going into your stomach, staying in your stomach. We call it the cardiac sphincter, and it's described as heartburn a lot of times. Remember, your heart is like right here. So this is just below the apex of the heart. Well, when you're feeling that burning sensation, you're kind of feeling at about the same level as the heart. So you really feel like your heart's burning, but obviously it's not. Our esophagus actually pierces through the diaphragm. I mentioned that previously. The opening in the diaphragm in which it does is called the esophageal hiatus. As we talked about earlier, I mentioned earlier, deglutition is the process of swallowing. It's a pretty complicated process. It begins with, what we can see, feel, and consciously control, where we're moving that bolus from our mouth into the oral pharynx, where the bolus is formed in the middle of the tongue. We push it upward against the palate. Food is then moved into the oral pharynx. This is the only voluntarily controlled process. From there on, it's involuntary, involving the pharynx and then the esophagus. So we call those the pharyngeal and the esophageal stages. The pharyngeal stage moves that bolus into the esophagus from the oropharynx. The mouth, the nasopharynx, and larynx must be blocked. A combination of contractions and gravity help perform this. And then the final stage is where the contraction and gravity move that bolus through the esophagus into the stomach. To prevent aspiration into our lungs, our nasopharynx, or to prevent aspiration into our lungs and food and drink into our nasopharynx, our uvula, remember that's a little ball that hangs down from the rear, will move up. And we talked a little bit about this the other day, closing off the nasal cavity. The larynx pulls forward under the protection of the tongue. The epiglottis, that flap that's right in here, will close the opening to the trachea. Food slides over the epiglottis into the esophagus, and our vocal cords within the larynx close to block the airway some more. And so it's impossible to breathe while you're swallowing, but it's not a long period of time, only about 2 seconds. Over on the right is an illustration showing you the layers of the esophagus from a cadaver, showing you that there are the 4 layers like we just talked about the other day, except they've not included, there is not a serosa, that's right. That's around the esophagus. There's obviously the mucosa, submucosa, and then muscularis, and its 2 layers are visible. Pictures on this page, though, not important, so don't worry about them for the exam. All right, moving on down the track, we will now move into the stomach, just like the food would. Okay, our stomach is a portion of our digestive tube that can dilate or expand into an elongated pouch-like structure because of accordion-like folds that can expand, what we call rugae. Here's a really nice picture to show the rugae. This is a sectioned open stomach, so basically the front of the stomach's been cut away. You can see those folds very nicely. That's from a cadaver. Here's kind of the cartoonistic version of it, although they've included part of the front of the stomach to show you some of those layers. The rugae are specialized structures of the mucosa layer, that inner layer of the stomach. Location of the stomach is the upper part of our abdominal cavity under the liver and diaphragm, and it functions to mix saliva, food, and gastric juice, forming what we call chyme. Chyme is just a collection of those different things, so we'll kind of try to shy away from saying food at this point, because it's not just food anymore. Our stomach also serves as a reservoir for food before being released in the small intestine. Gastric juice is secreted to aid in digestion, not aid and digestion. Aid in digestion. Our stomach actually secretes hormone, gastrin, into the blood. There's another hormone that I'm not going to get into called ghrelin. And then our stomach helps kill bacteria via the action of hydrochloric acid, HCl for short. Anytime you see the word gastric, like gastric juice that I ever mentioned, or gastric pits that you had to write down, you should know that we're dealing with the stomach. Okay. So let's talk about those gastric pits. Gastric pits are kind of exactly what they sound like. They're little depressions or pits within the mucosa of the stomach. Here, if we zoom in at one, we find that there are many different types of cells within a gastric pit. Okay, so let's read through. Okay. Mucosal layer also contains specialized structures known as gastric pits, penetrate deep into the layer, forming ducts of various gastric glands. So let's talk about the glands and cells that are part of the pits. We can kind of classify them into two categories, exocrine and endocrine. Exocrine glands are going to collectively form what's called gastric juice. The juice that's released into the lumen of the stomach. So the secretion will go out and then out into the lumen. First type of cells that are exocrine in nature are mucus surface cells. Now, there's two types of mucus producing cells, mucus neck cells, like you can see here, and surface mucus cells. You can see in parentheses, they have the same function to produce and release cells, to release mucus. The surface cells are also known as goblet cells, making up the surface layer of simple columnar epithelium, secreting a thick glycoprotein mucus. And that mucus helps protect the stomach from that acid that it's going to produce along with the digestive enzymes. So it's a really thick mucus, and that's why your stomach is not going to burn like your esophagus or your small intestine would. We just talked about reflux disease, how that burning sensation occurs in your esophagus. Well, it's the same acid that's in the stomach. The stomach's just protected better than your esophagus. Okay. The neck cells are going to line the upper walls of the ducts, helping to secrete that protective mucus just like the surface cells did. Parietal cells, which is kind of the term that is typically more used, are also known as oxyntic cells, found throughout the neck and the lower walls of the ducts. They secrete hydrochloric acid, hydrogen ion, and a chemical called intrinsic factor that helps us absorb vitamin B12. Chief, that's probably the way that I would want you to know it. They're also known as zymogenic cells. They're found lower in the pit, and they secrete pepsinogen, which is a precursor to what's called pepsin, helps us digest proteins, and then gastric lipase that helps us digest fat. Okay. The endocrine cells that secrete not into the lumen of the stomach, but instead into the blood, are what we call enteroendocrine cells, or G cells, that secrete various hormones like gastrin, stimulating other stomach glands to increase their output. So that's the function of them. I don't really want to talk much about the submucosa of the stomach, not too much importance there, but I do want to talk about the muscularis. Muscularis, remember, is where the muscle is, and I mentioned this the other day, but something unique about the muscularis of our stomach is that it has actually 3 layers. This is the only portion of the intestinal tract that's got, or excuse me, the GI tract that's got 3 layers. There's an outer longitudinal, there's a circular, and then there's an innermost oblique layer. And this is going to help really kind of squeeze and just do a lot of rocking the boat of our stomach, mixing that stuff up, digesting it inside our stomach. Okay. Now, our stomach is divided into 4 segments or sections. You can see they're put in the picture here in all caps and bracketed off. These dotted lines actually don't exist. Obviously, you don't see them here. So they're just imaginary lines. The kind of smallest portion is your cardia, the collar-like region at the junction of the esophagus, where that lower esophageal sphincter or cardiac sphincter will be located. Just above that is kind of this weird area is what we call a fundus. It's to the left and above the opening of the esophagus into the stomach. The biggest region of the stomach is what we call the body, which is just the central portion. And then it starts to taper or kind of get skinnier where it joins with the duodenum, the small intestine. We call this the pylorus. Okay? Now the pylorus consists of 2 parts. We can see they're kind of bracketed out here. A pyloric antrum, which connects to the body, and then the pyloric canal, which leads to the duodenum. Right there between the duodenum and that pyloric canal is what we call a pyloric sphincter. Like the lower esophageal sphincter, it controls the movement of, we'll call it chyme at this time, out of the stomach. So food goes in, it has to pass through the lower esophageal sphincter. The pyloric sphincter allows the stuff to leave the stomach. And it's not just going to let everything go out at once. It's going to do so in small waves. And it's going to take like 2 to 6 hours to completely empty your stomach. Okay. As far as the pictures go, this is the one to know. And I would say make sure you just know everything in it. We didn't talk about some of the stuff. I mean, we know that there should be a serosa around it. There's a lesser curvature, a greater curvature. I didn't even list anything. They're pretty common sense, I would think anyway. So make sure you know it for Tuesday. Okay, now what we're going to do is, instead of moving directly to the duodenum and the rest of the small intestine, we're going to take kind of a detour and talk about 3 accessory organs. 3 accessory organs, and you'll see why, include the pancreas that we'll talk about on this page, and then the gallbladder and liver on the next page. Okay, your pancreas is an organ we've talked about before. Remember, it has cells, what we call pancreatic islets, that produce hormones like insulin, glucagon. We talked about that back in our endocrine system. And at the time, I kind of just briefly talked a little bit about the pancreas, not much about its kind of overall anatomy. So we'll kind of do that here. It's a retroperitoneal organ, meaning that it lies behind the peritoneum, so it's behind the peritoneal cavity. It's posterior to the greater curvature of your stomach, about 12 inches long, tapering from right to left. It kind of has feeling like a sports pennant. It's kind of that shape, kind of wide on one end, and it comes to a point on the other. The point is on the left side of your abdomen. That point is what we call the tail. Okay, the head is the widest part. It's nestled in what we call the duodenal sweep. And then in between those is the body, okay, which just traverses up to the left. Tail of the pancreas terminates at the junction with the spleen. Posterior wall of the stomach lies against the anterior surface of our pancreas. Word pancreas actually means all flesh because of its ability to digest virtually all proteins. Secretions of the pancreas are called pancreatic juice, produced in clusters of exocrine cells known as acini. Acini is plural. Acinor would be singular, and those account for 99% of the cells in the pancreas. Okay, so those are the cells that we haven't talked about yet. Collectively, they create this fluid that then drains along a kind of complicated, but not super complicated, duct system. Okay, it begins with small ducts, ultimately uniting to form 2 larger ducts, what we call a pancreatic duct or duct of Wirsung, and then an accessory duct called the duct of Santorini. I'm not going to worry about the names in parentheses, just the 2 names that you had to write down. Your pancreatic duct is the larger of the 2. It begins all the way back up there by the tail and then runs all the way through. And then it dumps that pancreatic juice into the duodenum. Okay, at this point right here, the accessory duct also dumps pancreatic juice into the duodenum, just actually a little bit above the pancreatic duct. Okay, so let's read about it. Pancreatic duct, larger of the 2. In most people, it joins the common bile duct from our liver and gallbladder, enters the duodenum as a dilated common duct called the hepatopancreatic ampulla or ampulla vator, opens on an elevation of the duodenal mucosa known as the major duodenal papilla, lies about 10 centimeters or 4 inches inferior to the pyloric sphincter. Passage of pancreatic juice from the pancreas and bile from the liver and gallbladder is regulated by a massive smooth muscle surrounding the ampulla known as the sphincter of the hepatopancreatic ampulla. So what this means and what I basically just read is there's going to be chemicals coming down from the liver and gallbladder by way of this green duct, what we call the common bile duct. Okay, if we zoom in at this little box here, what this is, common bile duct and that pancreatic duct come together, forming a kind of fatter duct, and they've kind of done a nice job coloring it part green, part purple. That common duct is called the hepatopancreatic ampulla. Okay, it dumps into the duodenum, so there's going to be chemicals coming from the liver and gallbladder, the pancreatic juice from the pancreas. They dump into the duodenum at the same spot in what we call the major duodenal papilla. There's a little ring of muscle. That's the sphincter that I just mentioned that regulates the movement of those chemicals into the duodenum. So that's why I kind of wanted to take a break on or a detour away from the tract to talk about these three organs that dump into the duodenum before we talked about the duodenum. Okay. Now, here on the next page, we're going to talk about these different ducts and the different organs that I just mentioned, the liver and the gallbladder. So I'm going to wait and tell you what to highlight here in just a minute for those. Okay. I already talked about the other 1% of the cells that we call islets of Langerhans or pancreatic islets, producing those hormones. Pancreas is very richly supplied with arteries and veins. There's a lot of different arteries that feed it. I'm not going to read through them all. We kind of talked about that already. And is innervated by our vagus nerves, providing parasympathetic innervation. Okay, looking at these pictures, like I said, we'll kind of come back to and tell you what to highlight here in just a second. This is a cadaver version. Pretty cool to see. They've kind of opened things up to show the ducts. There's that common bile duct. There's the major duodenal papilla, and those two unite. There's the duodenum. Kind of cool to see. Nothing I'm going to ask you to know, though, for the exam. Okay. Our next organ is the largest internal organ, our liver. Not the largest of the body because that's your skin. But notice I said internal organ. Okay. Our liver weighs about 1.5 kilos or 3 pounds, which is not super big or super heavy, but still it's a pretty good sized organ. It aids in digestion by producing bile. I'll talk about bile here in just a little bit. Also performs metabolism of our carbs, lipids, and proteins. Detoxifies like drugs and alcohol. Stores certain vitamins and minerals. There are phagocytes inside that kind of chew up and digest different things. Stores vitamins. I guess I listed that there twice. Excretes bilirubin, which is a byproduct of the breakdown of hemoglobin from our blood. We help activate vitamin D, and we process drugs and hormones. Two principal lobes of the liver exist, a right lobe and a left lobe. Looking at this picture, the same picture that we just had on the previous page, notice there's a very distinct difference in size. Okay, they're split in half, or I shouldn't say in half because that's a terrible way of saying it, but they're split by way of that falciform ligament we mentioned earlier. Your left lobe is only about 1/6 in size of the total liver, whereas the right lobe forms the other 5/6. Okay. There's actually several sublobes to the right lobe, inferior quadrate and a posterior caudate. Those aren't labeled in this picture, but they are, something that I wanted to mention. The functional or anatomical units of the liver are what we call hepatic lobules. Here's what a lobule looks like. Here's what a part of a lobule looks like. Within each lobule, there are hepatocytes or functional liver cells arranged in layers radiating out from a central vein. Okay, here's that central vein, called central vein because it's at the center. And then you can kind of think of these cells like rings on a tree and circles all the way around to the outside. Notice that central vein has these kind of projecting outward blood vessel extensions. Okay, let's read through some more. One of the major functions of those hepatocytes is to secrete bile, a liquid that aids in the digestion of fats. And that bile is going to end up dumping into our duodenum that we were kind of talking about earlier. Hepatic sinusoids are highly permeable blood capillaries that are located between the rows of hepatocytes, receiving oxygenated blood from the hepatic artery, and then nutrient-rich deoxygenated blood from that hepatic portal vein. Remember, the hepatic portal vein is the vein that's connected to our intestines and stomach and that kind of stuff, carries blood into your liver after already going through those other organs. Hepatic sinusoids converge and deliver blood into the central vein, which then flows into the hepatic vein that drains into the inferior vena cava. So looking at the figure here, the sinusoids are these projections out from that central vein. Okay, the blood is going towards the central vein like we show here. So the blood's coming in into that central vein, which will eventually lead the blood out to the hepatic vein that delivers it back into that inferior vena cava that we previously learned about. Okay, over here in green, we show what we call bile ducts. Okay, and what we call bile canaliculi, small ducts that are located between the hepatocytes that collect bile that's produced by those hepatocytes. From there, the bile passes into bile ductules and then to the actual bile duct that's shown right there. The bile ducts merge and eventually form larger right and left hepatic ducts. Hepatic always refers to liver, so those are found within the liver. Right hepatic duct, left hepatic duct converge, coming together to form a common hepatic duct. And that joins with the cystic duct from the gallbladder, forming a common bile duct. So here's kind of a flow chart to keep your head straight. Right hepatic duct, left hepatic duct come together. Common hepatic duct is formed. The cystic duct is connected to the gallbladder. The cystic duct and the common hepatic duct come together, forming that common bile duct. And then the common bile duct, remember, joins the pancreatic duct, dumping that set of secretions into the small intestine. Okay, let's talk about the gallbladder, a pear-shaped sac located in the depression on the posterior surface of our liver. Pretty small, about 7 to 10 centimeters or 3 to 4 inches in length. 3 parts of it exist: a broad fundus projecting inferiorly beyond the inferior border of the liver. So that's kind of the only part that you can see just from the front of the liver, just kind of poking out underneath. There's a body, the central portion, and then the neck, which tapers to join with that cystic duct. Okay. What it is, it's just a soft, thin-walled sac with narrow end pointing toward the bile ducts. And here's what I want you to kind of really definitely know as far as function goes. It stores and concentrates bile that's produced by our liver until it's needed in our small intestine. Bile comes here from the bile ducts, hepatic ducts, and the cystic duct. And when it is ready to release that bile, it contracts due to muscle fibers within it, injecting that bile into the cystic duct, which then joins with that common hepatic duct, forming that common bile duct that I've mentioned. Okay, as far as the pictures go, here's kind of a cool view of what we can see from the pancreas, the gallbladder, the liver. The liver's actually been cut a little bit here to show, but we can see the duct, at least part of the duct networking. I would go back to the previous page. I think this picture is a little bit bigger than the one that's on that page. where this would be a little bit easier to kind of identify the things that I want you to highlight. So looking here, I'll just kind of start here on the left side. I would highlight everything. I don't know why, it drives me nuts when I do this, but highlight within the picture the cystic duct, right hepatic duct, and then the right lobe of the liver. Same thing for left lobe of the liver, that's in there. And then the pancreas, I guess, down there at the bottom. On top, highlight the falciform ligament. That's what's running down through the middle. I shouldn't say middle, but it runs through the middle of the body. It just keeps, creates the unequal sized lobes. Don't worry about any of the other stuff up here at the top. I do want you to know the left hepatic duct, the common hepatic duct, common bile duct, and then the tail, the body, pancreatic duct, and then the head. Go ahead and also highlight the stuff that's on this part of the picture, with the exception of mucosa of duodenum. Since that's zooming out on this picture, you can see those things really nicely, so make sure you know it. Once again, don't worry about the mucosa of the duodenum. Anything that's in parentheses, you know, these other names, don't worry about those, just the name that's first. Hopefully it shouldn't be too terrible for you. Pretty important image since it covers, you know, 3 different organs, you know, hitting them. 3 birds with 1 stone, as they say. Not that they ever say that, but you know what I'm saying. Okay, now we can talk about the duodenum and the other parts of the small intestine. Moving back to the tract. I've had professors, instructors pronounce this term a lot of different ways. We've heard it duodenum, duodenum. I just say duodenum. I don't know which one's correct. Probably make a case for all 3. But though the duodenum is the first of the 3, the jejunum and the ileum are the next 2. That's I-L-E-U-M, not L-L, if you were wondering, not I-I-E-U-M either. I hate the way that I and L look the same when you type them. All right, our small intestine is approximately 2.5 centimeters or 1 inch in diameter. This is why we call it the small intestine, not for its length, because it's really long. It's 3 meters or so, about 10 feet. If you go back to that very first slide, when we talked about the tract itself, we learned that it is about 16.5 to 23 feet in length in a living person. So, you know, it could be over right at half of the entire length of the tract. And because it's so long, it allows for a lot of digestion and absorption to take place, which is, as it states here, the main site of absorption in the GI tract. This is the main place where we pull stuff in from the wall or through the wall into the blood or into the lymph. It also functions in mechanically digestion by segmentation peristalsis. A lot of chemicals like the bile and the pancreatic juice, along with fluids produced by it itself, help with chemical digestion. Obviously, absorption of nutrients, as I already mentioned, is a function as well. The duodenum is the shortest region, runs from the pyloric sphincter of the stomach to what we call the ligament of Treitz. I'm not even going to really talk about that. Receives chyme from the stomach through that pyloric sphincter. Kind of has a C shape, is only about 10 inches or 25 centimeters in length. So it kind of just like curves right out of the stomach, and then The next segment is called the jejunum. Runs from the ligaments to the ilium. It's about 3 feet in length, 1 meter. So we've gone about almost 4 feet, which means the last 6 or so feet would be the ilium. The final and longest region runs from the mid-small bowel to what we call the, looks like you needed to fill this in if you haven't already, what we call the ileocecal sphincter. Called the ileocecal sphincter because it's between the ilium and the cecum. Cecal for cecum, which is the first part of the large intestine. We'll talk about it on the next page. It prevents that chyme that's entered the large intestine from going back into the small intestine. So by having, about 10 feet of length, there's a lot of ability to get digestion absorption done. But there's also other features that increase its surface area, making it really adaptable and great for digesting and absorbing. These are what we call circular folds, villi, and microvilli. Circular folds, also known as plicae, are folds of the mucosa and submucosa, about 10 millimeters in length. Okay, if we look at this illustration where we've opened up the tract, we can kind of see it nicely. Over here, this is actually cadaver intestine, small intestine that's been opened up. We can really see those folds, and they're very big and visible with the naked eye, like we show here with the entire small intestine. Okay. They are formed, like I said, from projections of the mucosa and a little bit of the submucosa as well. Okay. Coming off of those are even smaller finger-like in projections. These are specifically from the mucosa called villi. We look at this picture nicely zoomed in. The finger-like plicae or circular folds, you can see they have little finger-like extensions coming off of them, even smaller, but very important. Here's what a couple of them look like. Okay, that's what a villus is. Villus is singular, villi is plural. These are about 1/2 to 1 millimeter in length. Inside of them, you'll find an arterial, a venual, and a blood capillary network, like we show right here. The red arterial, the blue venual, and then the connection between them is the capillary. This is where we're going to pick up the stuff from the blood, or from the tract, and pull it into the blood. That's for the carbs and proteins and vitamins and minerals, along with water go. Fats go into these green, what we call lacteal capillaries. Green is always denoting the lymphatic system, as we've recently talked about. We talked about lacteals in that lecture. This is where we absorb fats. I don't know why fats have to go into the lymph, whereas everything else goes into the blood, but that's just what happens, okay? So nutrients absorbed by the epithelial cells covering the villus pass through the wall of a capillary or a lacteal to enter our blood or lymph, respectively. The outer epithelial layer or facing the lumen includes the following cell types, which you can see are labeled here. We have absorptive cells. Guess what they do? They're the ones that do the absorbing. They also release different enzymes, so help with digestion. Goblet cells, just like any other goblet cells, secrete mucus, helping to protect the epithelial layer from digestion. Pannid cells that secrete lysozyme to help kill bacteria. And then enteroendocrine cells that secrete hormones in the blood that penetrates the villus. So we secrete hormones in the small intestine as well. Now, if I zoom in at this absorptive cell, we see that those cells have little finger-like extensions called microvilli. That's our third extension to help increase surface area. They're only found on the absorptive cells, but they face the lumen of the small intestine. And we've talked about this before, but microvilli look like a little brush, so that's why they call it a brush border. There's also glands that are found throughout the walls of our small intestine. Intestinal glands, or crypts of Lieberkreuz, secrete intestinal juice located in the mucosa. Duodenal or Brunner's glands found in the submucosa secrete an alkaline mucus, which helps neutralize the gastric acid that's in the chyme. Within the mucosa, and specifically the lamina propria of it, are those mucosa-associated lymphoid tissues that we previously learned about, called Peyer's patches, and that would be specific to the ileum. But we've talked about those before, so I thought I'd mention them again. Okay, so your small intestine is super long, and then it's got folds, which have little finger-like folds, which have cells that have little finger-like folds. It's going to fold, unfolds, unfolds. Really, really, really increased surface area, which makes it really good at digestion. Pictures, I don't like any of them, really, to be honest, so don't worry about them for the exam. I can't say the same because I do like this picture or pictures at the bottom of this page. Where we're looking at the large intestine, our last organ of the digestive tract and digestive system, which gets its name not for its length, although it's pretty good size in length, but it's a lot wider than the small intestine. All right, let's talk large intestine. Like I said, it's a lot wider than the small. Its diameter is about 6 centimeters, which would be a little over 2 inches. Length is 1.5 to 1.8 meters, or 5 to 6 feet. So it's about half as long as the small intestine. Designed for absorbing water. There's some cool features of the large intestine. It has these little pouch-like structures. What each of these little pouches is called is a haustra. We've got 2 labeled here. What's really cool is basically we perform what's called haustral churning. When that, we'll call it chyme, since it's not quite food, arrives in the large intestine, as it passes from haustra to haustra, we churn it up. Okay, so we kind of complete the digestive processes. We pull out any of the remaining water that we want, and ultimately what's formed is feces. Okay, haustra are formed by gatherings of smooth muscle of the muscularis layer at regular distances. Okay. The longitudinal muscles that make up, or the longitudinal muscle that makes up the wall of the muscularis, forms these conspicuous bands that you can see throughout the entirety of the tract. That is what we call tinea coli. Okay, run most of the length of the large intestine, and attached to them, you can see these kind of little yellow blobby-like things are fatty, what we call omental appendices. Okay, I don't really know why we have them, but that's what we have. Okay, 2 key divisions of the large intestine exists. We've opened up to show the cecum, which is kind of the dumbest feature of the entire tract because it's a wrong way. Okay, it's a dead end. Okay, the chyme's going to come in from the ileum through the ileocecal sphincter or ileocecal valve. And what we need is for the chyme to go up, but there's this little blind pouch that leads to nowhere. That's called the cecum. Okay. In other animals, it's more pronounced, but in us, it's really just kind of dumb. Coming off of it is that appendix or vermiform appendix, as it's listed as here, that we've talked about before. Okay. Part of our lymphatic system. Our appendix is held to the mesentery, or that has its own mesentery, I should say, called the mesoappendix. That's labeled here as well. The rest of the large intestine is called the colon. There's an ascending that carries the chyme up, and then comes across, transverse, down, descending, back to the middle with this kind of S-shaped sigmoid. and then straight down by the rectum. Ascending runs up the right side of the abdomen to the inferior surface of the liver. It then takes a left turn at what we call the right colic or hepatic flexure. Okay, the transverse comes across, and then it down turns another left, I guess this would be a left turn, but down at what we call the left colic or splenic flexure. The rectum is the last 7 or 8 inches of the intestinal tube, and the very last inch of that is what we call the anal canal, which we show here in brackets. Leads to the opening, what we call the anus. On both sides of the anal canal are muscles that control the release of feces. The internal anal sphincter is made up of involuntary smooth muscle. It's easy to remember that it's involuntary because the letters I, N are at the beginning of involuntary, and they're at the beginning of internal. That's the easiest way to remember it. Internal, involuntary. The external is the one that we gain voluntary control of once we hit, the potty train stage. We'll see kind of the same thing with the urethra for peeing. And the external is voluntarily controlled skeletal muscle that we can, contract when it's not a good time to go, and then relax when it is a good time in order to, allow us to go to the bathroom or not go to the bathroom if it's not a good time. Okay, make sure you know both of these pictures. Picture at the bottom just kind of showing the 4 layers and that, some of those same features that we talked about. In other places, there are these indentations, just like kind of what we saw in the stomach. But I decided really not to focus on those too much. There's not as many cells. We don't do a whole lot of, digesting, absorbing in the large intestine. Really, it's just pulling out water at this point. And then, what's going to be left is just, going to become feces. So. Any questions?